Okay. Good morning. Welcome to Project Echo. We've got a presentation from Ed Kaiser today on buprenorphine prescribing. A couple of quick housekeeping things, and then I'll turn it over to Ed. Here we go. This slide here just states that all those involved in Project Echo have no financial relationship to disclose. And then our funding statement, we acknowledge our partners at Nebraska DHHS for helping make this training possible. We are funded by the State Opioid Response Grant. That's a federal grant that comes through Nebraska DHHS and is passed on to us to make these trainings possible. And lastly, the certificate. I think most of you are pretty familiar with this process by this point. You'll receive a quick survey at the end of the training in the chat, and then I'll also email one out probably within a couple of hours after the training. If you don't see the survey by the end of the morning, check your junk or spam folder. I had a few people last week where it ended up in their junk folder for some reason from me. So yeah, anyway, do a quick survey and you will receive a survey certificate automatically. It'll pop up right after completing that survey. And again, I think I recognize most of the names on here. I think everyone knows what Project Echo is, but for those of you who might be new today, these are ongoing trainings on pain and substance use disorders. ECHO stands for Extension for Community Healthcare Outcomes. So we've got a great group of 6 experts, sort of our hub team, who are able to do these trainings on an ongoing basis. And part of these trainings also involves the opportunity for case consultation or just general questions during the training. We have time built in for that. We can also make consultation available outside of these trainings. The best way to do that is just to get in touch with me, and I can put you in touch with one of our experts. Speaking of our experts, we've got 6 great experts, and I'll let them introduce themselves. Janet, do you want to start?
Okay, hi, I'm Janet Bernard. I'm a retired family practice doctor from North Platte. I started treating opiate use disorder in 2008 with buprenorphine and related substances. Thank you.
Gail? Oh, you're on mute, Gail.
Good morning. I'm Gail Keller. I'm a nurse practitioner down in Fall City. I have been treating patients with buprenorphine over the last few years.
Thank you. Stephanie.
Hello, I'm Stephanie Bennington. I'm a psychiatrist in Omaha with a special interest in treating substance use disorders.
Thanks. I don't think John and Todd are on today, so if you are, John, Todd, speak up. I don't see you. Otherwise, okay, Ed, I'm going to turn over to you.
Okay. Yeah, thanks a lot, Will. Yeah, excited to be with you guys today. Just going to see if I can get my screen share to work correctly here. All right, there we go. Yeah. So yeah, my name's Ed Kaiser. I'm a nurse practitioner here in Omaha, Nebraska. Have had the opportunity to treat patients with substance use disorder for about the last 5 years. And so really excited to do this training with y'all. I am really passionate about this patient population, and we use Suboxone primarily in our practice. So yeah, I'm going to dive into kind of a lot of information here, but before I do that, I just want to be honest with you up front. One of the things I'm trying to do today is really convince you to prescribe Suboxone. Obviously, I want you to feel safe in doing that, but there's a huge need out there for patients to have access to this medication. So I want to convince you to do that. Real quick story. So when I started treating patients with substance use disorder, I was trained by a doc out in Washington. I have a background in ER, and he was an ER doc. And so he was doing some training at that time. It was a little over 10 years ago, probably similar to what maybe some of us are doing today, like continuing education that we had to do. So he was doing the X-waiver training while he was working in the ER, probably half paying attention to it, but just to get education hours. And so he did the training, got the X-waiver, which you don't have to do anymore, but can prescribe buprenorphine. And about 2 months later, the DEA agent showed up in the ER and wanted to talk to him about his X waiver. So he obviously was a little nervous about that, as maybe any of us would be when the DEA agent shows up. And so he was just telling him, hey, I did the training. I haven't even prescribed the medication. I haven't done anything wrong. And so the DEA agent looks at him and says, the way he tells the story, he says, hey, this medication is going to save people's lives. You need to be prescribing it. And so that moment was such a mismatch experience for him, that he began to look into it more. He started seeing patients with substance use disorder. And so he's been doing that for over 10 years and has helped a lot of people. And so again, my charge is sort of the same. Hey, like, this medicine will save people's lives. And so I want you to feel comfortable prescribing it. All right, we got some learning outcomes here. Again, we'll kind of go over all of these things, but we're just going to talk about buprenorphine at sort of a high level, review the different medications that are approved for opiate use disorder, and then we'll go into greater detail about the buprenorphine. Here's the agenda here. So again, we'll kind of cover each one of these topics, but different medications, some fast facts about buprenorphine. We'll talk about how the medication actually works. Gotta get this out of my way. There we go. We'll talk about how the medication actually works, dosing instructions. We got to talk about precipitated withdrawal when we talk about Suboxone, so we'll go over that. A few drug-drug interactions, side effects, special populations. So again, this is a long slide deck. I'm going to make sure I try to get through it on time, but this slide deck will be available to you after the presentation if you need it. All right, so let's talk about the options. So essentially, there's 3 FDA-approved medications for opiate use disorder. The initial one is methadone. Methadone has historically been considered the gold standard for medication for opiate use disorder. It is a full opiate agonist, and so it turns that opiate receptor on at 100%. It results in activation, but it also can include like help with pain, but it can cause euphoria and sedation as well. Buprenorphine, on the other hand, it is a less activated. It turns on that opiate receptor in a partial way, probably around 40 or 50%. So not as high as a pure opiate. And then the third medication here is the naltrexone, which naltrexone, essentially what it does is it blocks that opiate receptor. So it does not have any activation of the opiate receptor, but really just has a blockade of that. So those are the 3 main medications. This is kind of a busy slide, but again, more for your reference. But essentially, the variance in the clinical application and efficacy and safety profile of methadone, buprenorphine, and naltrexone is largely driven by the distinct mechanism of action of each of the medications. So again, methadone and buprenorphine are considered first-line management for opiate use disorder. Naltrexone maybe doesn't have the efficacy to be considered first-line option, but it is a helpful option to have in your tool belt. So by binding to and activating the opiate receptor, both methadone and buprenorphine can suppress withdrawal symptoms and cravings. Again, due to being a full agonist opiate, methadone tends to be associated with more euphoria, sedation, as opposed to buprenorphine. Most patients who take buprenorphine in the correct dose, what they'll report to you is just that they feel normal. So they don't feel high, they don't feel sleepy, there's no cognitive impairment. So it's really a great medication because people can just sort of feel like they're back to normal. Here's a slide on some sort of advantages and disadvantages. And again, most of these advantages and disadvantages are just based on the binding behavior of the methadone, buprenorphine, or the naltrexone. And so again, buprenorphine, methadone activate that receptor. And so because of that case, like if a patient is on buprenorphine or methadone, we definitely don't want to discontinue that medication all at once because it will turn into, people will get into like opiate withdrawal symptoms. With the methadone, because it's a full agonist, it can reach greater opiate receptor effect relative to buprenorphine. And so for certain patients, this can be a really a needed thing, especially patients who maybe have had a really bad fentanyl dependency and they cannot get symptom relief of withdrawals and cravings with the buprenorphine, even at maximum doses. So Again, methadone has been around for a long time, and for the right patient, it does really well. But again, methadone does have some, drug-drug interaction problems, has some more serious side effects. It does have a higher abuse potential. And so, again, you may know this, but methadone is primarily prescribed in a methadone clinic where people get like daily dosing. Sometimes they can get like week take homes, things like that. But again, it's a lot more regulated, where buprenorphine, you can prescribe this medication, send it to the pharmacy. Patients can take the medication at home. So, oh yeah, here we go. There's a few knowledge checks throughout here to kind of help highlight some of the main points. So the first one is which pharmacological property of buprenorphine makes it preferable to methadone for the treatment in outpatient setting. Don't worry, you don't have to jump on. I'm going to give you the answer. I didn't mention too, if you do have questions throughout this, throw your questions in the chat. And we'll try to leave some time at the end to kind of go over that. So again, the answer is, buprenorphine is a partial opiate receptor agonist, where methadone is a full agonist. And again, relative to methadone, buprenorphine has decreased abuse potential, improved safety profile, fewer drug-drug interactions, and has a protective blockade of the opiate receptor. So we'll go more into detail about that here in a few minutes. All right, so what is buprenorphine? So certain formulations of buprenorphine are FDA approved specifically for the management of opiate use disorder. There's a different subset of them that are specifically FDA approved for the management of chronic pain. So the formulations for buprenorphine approved for opiate use disorder kind of fall into two general categories. The first category is referred to as the monoproduct, which contains only buprenorphine. This is available in sort of a sublingual tablet, a generic tablet, or a name brand, which is Subutex, or else it also comes in an injectable form called Sublocade. The other category is the combination product. So generally, when people talk about Suboxone, they're talking about a combination product of buprenorphine and naloxone. And again, the naloxone is an opiate receptor antagonist. So we'll talk about that in a minute. But the combination product is available in the generic sublingual tablets or film strips. The brand name is Suboxone. There's also a brand name tablet called Zubsolv. And then the ones that are more for like chronic pain or severe pain is the Belbuca sublingual or the Butrans patch. Just a quick chart for you about the dosing available. So again, the combo product comes in a 2, 4, 8, and 12 milligram film strip, where the tablets are 2 and 4 milligrams. The strip Suboxone comes again in the same formulation. Zubsolv, the dosing of that in the tablet form, the name brand is a little bit different. We don't really need to go into details of why that is, but essentially like a 5 milligram is equivalent to an 8 milligram. There's dosing charts that you can look into to find that, or you can just look on Hippocrates. If you look up Zubsolv, it'll show you the dose equivalents to that. So generally, we talk in the dosing of the Suboxone. And then again, the Subutex just comes in a 2 and 8 milligram tablet. So one of the main things that is different about Suboxone is it's taken sublingually, so different than most medications. And the reason that this is done is because the medication, if you take it sublingually, is absorbed more into the body to where you can get it into a therapeutic range. So if somebody would just take Suboxone and swallow the medication, really less than 10% of that medication gets absorbed systemically. If somebody would take Suboxone and inject it or snort it, which a lot of patients who have a severe substance use disorder have had a history of injecting or snorting drugs, then that medication becomes available at 100%. So that's sort of the reason that the Suboxone is taken sublingually, is so that we can get the appropriate amount of medication to the patient that allows them to get the achievement of the withdrawal symptoms going away and to help with the cravings. All right. When I started on using Suboxone, I didn't fully understand this, but I think I have a better grasp of it now. So we got to take a minute to talk about naloxone versus naltrexone. So again, both medications are opiate receptor antagonists, but they have different clinical indications. So Naltrexone, again, is a long-acting opiate receptor antagonist. It's indicated for opiate use disorder and alcohol use disorder, and it comes in an oral form as well as a once-a-month injection. Now, naloxone is a short-acting opiate receptor antagonist, and essentially we primarily use this medication for opiate overdose. So you obviously probably are familiar with Narcan, the nasal spray. Kloxxado is a sort of a double dose of Narcan, but it comes in IV or IM form as well. So the real question is, why do you put a antagonist in with the agonist? And so the reason that the naloxone is added to the Suboxone or to the buprenorphine is to prevent abuse or misuse of the medication through IV or nasal inhalation. So individuals who would snort or inject Suboxone theoretically should not experience any effect of the buprenorphine because the naloxone component will get on that receptor in a stronger way than the buprenorphine will, and it should put someone into precipitated withdrawals. Now, I've had patients who have told me that they have shot or injected Suboxone before, and the reality is the naloxone is a short-acting medicine, so even though they may get an adverse effect for a little bit of time, that will wear off, and then the Suboxone is long-acting, or the buprenorphine. So it doesn't perfectly deter people from using or abusing the medication, but that's the reason it's in there, is because it does give people sort of an adverse effect if they abuse the medication, which is one of the reasons that the medication is safer for outpatient setting and doesn't have to be monitored like methadone does. All right, so how do you pick which formulation to put people on? I would just say personally, majority of my patients with opiate use disorder, we put them on the combination product, either the generic or the name brand film strip. Generally low cost, lower risk of diversion with this medication. If somebody's having side effects of the medication, which we'll dive into more, headaches, nausea, vomiting, sometimes peripheral edema with a combination product, generally what I will do is I will switch them over to the Zubsolv. That seems to usually fix those problems. Or we could also try Sublocade, the injectable form. But generally that's a little bit better with side effects. Now, if somebody has a type 1 hypersensitivity reaction to the Suboxone, obviously like anaphylactic, essentially what sometimes will happen with patients is, even though the naloxone is very minimally absorbed in any significant way, people can have an allergic reaction to that. And so sometimes we'll push them over to the Subutex or the Sublocade, and they'll do pretty well. As far as pregnant patients go, either medication is fine, the combo or the mono product. Obviously recommend that they talk to their OB about that, but I've had patients who have been on both mono and combo product throughout their whole pregnancy, have done really well. So generally patients do prefer the film strip over the tablets. It seems to dissolve a little bit easier, and maybe the taste is a little better, but patients do complain about the taste of Suboxone. It's not great. All right, quick slide here about, who can take Suboxone and who can't. So generally what we do is we, any patient with a DSM-5 criteria of opiate use disorder, again, pregnant patients are okay, adolescents are okay. If somebody's had a history of overdose, physical dependence on the opiates, or if they're abstinent and at risk for return to use. So this is sort of a unique population. Sometimes people will be incarcerated for a period of time and they won't have any access to opiates, and so they won't use. But once they get out, they are at risk for returning to use as well as overdose, or sometimes somebody has been in a treatment center. So those patients I definitely want to talk to about naltrexone. But the DSM-5 criteria does count for any sort of 12-month period. So even if it was 5 years ago, somebody struggled with this, but they've been in a different environment, but now they're at risk of going back to use, the buprenorphine can still be an option for them. Again, people that can't take it if they have a hypersensitivity reaction to the buprenorphine, or if they're currently on the naltrexone or Vivitrol, the Suboxone will not work for them. So let's talk for a minute about the duration of treatment. So again, this is ASAM from 2020, but there's limited research on the optimal length of addiction treatment. Available research suggests that longer duration of treatment results in better outcomes. So again, the way that I talk to my patients about this is that we view opiate use disorder as a chronic long-term disease process. So oftentimes, however patients got started using opiates, whether it was prescribed or whether it was recreational, they have developed a dependence on this, and the disease process is a relapsing disease that often will last for a lifetime that they'll be dealing with this. So some patients are able to get on Suboxone for a period of time, sort of stabilize their brain, change their environments, and eventually sort of wean off of the medication. And I'm fine to encourage my patients to do that. But I do want people to know that long-term treatment of Suboxone is safe and sometimes needed for people to be able to live the lives that they want to do and accomplish their goals. Have had patients that have been on Suboxone for over 10 years and are continuing to do well. So again, the chronic nature of the disease process, I talk to my patients about, diabetes or hypertension, so there's things that you change in your life, your diet, your exercise, but a lot of times a patient needs a medication on a daily basis to sort of help with that disease process. And so we view opiate use disorder and Suboxone in a similar way. All right, knowledge check number 2. Why is the combination product typically preferred over the mono product? And again, the answer is the combination product includes the naloxone, which mainly is just a deterrent for abuse of the medication and reduces the risk of diversion. All right, let's talk about how the buprenorphine actually works. So again, we kind of talked about this already, but the buprenorphine is a partial opiate agonist, binds to the opiate receptor partially, weaker to a full agonist, so it just turns it on at a partial percent, not at a full percent. And again, the full agonist being like methadone or fentanyl or oxycodone or hydrocodone, any of those opiates. So one of the things that makes Suboxone a really safe medication is the ceiling effect of Suboxone or buprenorphine. And so again, when you prescribe this medication, as people are taking it, there's only so many opiate receptors that are available in the brain to have an opiate agonist on them. And so as you prescribe more Suboxone, or as the dose of Suboxone goes up somewhere around 16 to 24 milligrams, almost all of those opiate receptors have the buprenorphine on there. And again, those receptors are only turned on at 50%. And so if somebody would abuse Suboxone or overtake the medication, and when I say abuse, I mean overtake the medication, even if they take doses up to 32 or 40 or even higher, if they take the whole prescription, they're not going to get more of a suppressing like CNS suppressant from it, because there's only so many receptors that can turn it on at a certain place. So this is a really cool part of how the medicine works that makes it really safe for patients. The other way that the medicine works here is this last point about the higher affinity for the mu opiate receptor relative to the full agonist. And so in the picture here, the buprenorphine are the little yellow dots, and let's say fentanyl is the green dots. But if both fentanyl or oxycodone or methadone are in the patient's system at the same time as the buprenorphine will actually remove that off of there and sit on that receptor. And so again, that higher, tighter affinity for the opiate receptor makes the medication really safe, and actually also helps prevent overdose for patients if they do have a return to use. So yeah, really cool how the medication works. This is just another slide that sort of highlights the ceiling effect of the medication. So again, on the x-axis here, we have the dose of opiates increasing, and then the threshold for overdose, or the intensity of the opiate effects, on the top. And so you can see there, sort of as the dose of Suboxone gets higher, you sort of meet this plateau, which is well below the threshold for overdose in most patients with substance use disorder. All right, here you go. Knowledge check number 3. True or false, the ceiling effect of buprenorphine, even at high doses, reduces the risk of respiratory depression relative to the full agonist of opiates. Y'all should get this one right. Again, the ceiling effect that we just talked about, again, reduces the risk of respiratory depression and stimulates the opiate receptor in a less full way. All right, so we got to talk about the dosing of the medication, which I've sort of briefly talked about, the sublingual. again, this is really important to sort of go over with your patients. So the long half-life of buprenorphine, generally recommended we do once a day dosing of the film strips. Generally, people will begin to feel better or relief of their withdrawal symptoms within 30 to 60 minutes after taking their first dose of medication. The medication does sort of peak in the patient's system at like 1 to 4 hours, and then it kind of slowly goes down. But again, is really a long half-life, stays in the system for about 3 days. So the one thing to note for patients that are taking the medication, it's okay to cut the tablets or the film strips into smaller amounts. I think on the actual, Suboxone thing, it says don't cut it, but we have all of our patients cut their doses into the appropriate doses. Sometimes they take the medicine more than once. But again, the dosing of the medication, it's really, really important that they take the medication correctly, because how well they absorb the medication is really going to be affected by the sublingual taking of the medication. I think I have a thing on that here in a couple seconds. So again, generally once a day dosing, but here's some reasons maybe that you would have patients split the dose. So in pregnancy, as they get later in gestation, sometimes patients will split the dose into twice a day dosing. The reason for this is the increased metabolism, blood fluid volumes increase. Sometimes we actually just have to increase patients' doses later on in pregnancy to sort of get them at a place where they're not having withdrawals or cravings. Another reason is for short-term acute or post-op pain. So obviously a lot of patients that are on Suboxone have, surgeries or procedures. And so post-operatively, generally, if we maybe increase the dose or split that up into twice a day or 4 times a day dosing, patients will get enough pain relief from the medication to do it that way. Again, the third reason listed here is just patient preference. Again, I would say that 50% of the patients that are in our practice choose to take their medication twice a day. Again, we're fine with that. Some people are just in a habit of taking the medicine twice a day. If they prefer that, that's fine. The only thing I like to sort of stay away from is patients that are taking it multiple times a day that are not taking it for pain, because sometimes they can get in a habit of sort of taking Suboxone when they feel like, something is going on, like they're stressed about something or they're whatever, then they take a medication. So we want to get them out of that pattern of taking something because they feel like they need it. Really just trying to take it at a set time twice a day is going to allow the medicine to sort of build up in the patient's system the best. So again, here's just a helpful slide for you to maybe have access to. Again, I probably have this conversation multiple times a day, especially with new patients, but the main things to remember is when you're taking Suboxone, what we recommend is no eating, drinking, smoking, brushing your teeth for 30 minutes before you take your medication. When you do take the medication, you're going to want to put it underneath your tongue. You're going to want to allow it to dissolve and then try to hold the medication as well as the saliva in your mouth for about 15 to 20 minutes after. After that case, the patient can spit the medication out. They don't have to swallow it. It's not going to be harmful for them to swallow, but generally they may have less side effects if they spit the medication out. And then again, additional 30 minutes afterwards of no eating, drinking, or smoking. Vaping is included in that. And so, what did I do with lost my mouse here. There we go. Where are we at? There we go. So again, making sure the patients are not vaping either is really important before and after, because it'll affect the absorption of the medication. Again, the nicotine call out is just this: because of the medicine absorbed, underneath the tongue and the mucosa of the mouth, like nicotine constricts those vessels. And so it really has a significant effect. I could tell you multiple stories of patients who are like, oh, I've been on the medicine for a little while, or like my levels of medicine used to be good, but now I'm feeling withdrawals. And you ask them about nicotine and they're like, oh yeah, well, I smoke right after I smoke while I have the medicine in my mouth. And so when they stop doing that, they see a significant improvement in how they feel. Essentially, like the coffee stuff can change the pH of the mouth. And so that's why I want people to avoid that. All right, so true or false, most patients should be educated to take their buprenorphine for opiate use disorder as a once daily dose. that is true. Due to the long half-life of the medication, 24 to 48 hours, once a day dosing is preferred. All right, again, so let's talk a little bit about precipitated withdrawals. It's really important that you understand what precipitated withdrawals are and how they happen as you're educating patients who you're going to prescribe Suboxone to. So again, essentially, what is happening is when somebody goes into precipitated withdrawal, they have a full agonist, methadone, heroin, fentanyl, something on that opiate receptor. You take an antagonist, a full antagonist, which would be like Narcan, or a partial antagonist, which would be like buprenorphine. And what happens is as that gets displaced, the dopamine levels drop significantly. And what this does, what precipitated withdrawals does is it is sort of like bad withdrawal symptoms, like all at once. And so this is, so sometimes patients will get access to, Suboxone off the street or whatever. And so they don't fully understand this, but when you talk to them about it, when they come into the clinic, like, people only will make this mistake one time. Like, it is such a terrible experience for patients to go into precipitated withdrawals. If they have the opiate on board and they don't wait long enough and they take the Suboxone, it's sort of like a car going 100 miles an hour and the brakes being slammed on down to like 40 miles an hour. And so they get severe body aches, sweats, all the withdrawal symptoms, like a terrible flu all at once. Sometimes patients actually end up in the ER because they feel so terrible. But really educating patients on like what is happening here with the precipitated withdrawals and how to avoid it is important. So again, we spend a lot of time training patients on what this is. And sometimes patients will come in and they say, hey, I'm allergic to Suboxone, or I'm allergic to, the naloxone. And what happens is they actually took it too soon one time and put themselves into precipitated withdrawal. So again, signs and symptoms are similar to those of spontaneous withdrawal. Generally, this will happen about 30 to 90 minutes after the patient takes the medication. That's sort of when the medication starts to kick in. Typically, doses as small as 2 to 4 milligrams can initiate a precipitated withdrawal. So kind of want to be mindful of that. The symptoms of precipitated withdrawal can last 24 to 48 hours. So again, it's really a miserable place to find themselves. So we'll talk about how to help patients get out of this if they get into it. So again, how to overcome precipitated withdrawal. Again, we're available to help with some of these conversations if this happens to your patient. But essentially, the best thing to do to help someone get out of precipitated withdrawal is to actually prescribe or take more Suboxone. So what happens in this kind of picture right here is like the patient has some opiate on board, they take some Suboxone, it displaces whatever opiate is in their system, the dopamine levels drop, and they start to feel really lousy. Now, if you don't educate patients about this ahead of time, they're going to be very hesitant to take more Suboxone. But if you can convince them to take more Suboxone, or if you talk about it ahead of time of what may happen if they get themselves into precipitated withdrawal, if they take more Suboxone, eventually what happens is that opiate receptor gets turned on by more opiate receptors having the Suboxone on board. And then patients begin to have enough dopamine on board where they start to feel better. Again, somewhere around, 8 to 16 milligrams, sometimes 12 milligrams, adding that to what they've already taken will generally help patients get out of it, depending on how severe their opiate dependence is. Okay, so what's the mechanism by which buprenorphine can precipitate withdrawal in the opiate dependent patient? Again, it's this high affinity for the opiate receptor. So the ability for that Suboxone to sit on that receptor tightly leads to the rapid decrease in the opiate effects and the sensation of the severe withdrawal. So, all right, checking my time so I can get through all this for you. All right, so let's talk about drug-drug interactions. Again, buprenorphine is much more favorable as far as safety compared to methadone, but there are some drug-drug interactions that we sort of need to talk about to make sure that you're aware of. So there have been some studies that show the potential adverse interactions between the buprenorphine and central nervous system depressants. benzodiazepines, barbiturates, gabapentin, muscle relaxers, all of those things can cause increased sedation with the Suboxone. The second point here is really important though. Like, while combined use of central nervous system depressants increase the risk of oversedation in respiratory depression, essentially the harm caused by untreated opiate use disorder can far outweigh these risks. And so again, patients with opiate use disorder, even if they have an alcohol use disorder, a sedative use disorder, anti-anxiety medications, like, they may require a little bit more monitoring, but it doesn't disqualify patients from being on Suboxone. And really, these patients, if they do have an opiate use disorder, should be offered the treatment. So here's again just a quick list for you of some of the high risk medications. The way I just try to simply have this conversation with my patients is I just say, hey, the two things that are most dangerous with Suboxone are alcohol and benzodiazepines. So if a patient is prescribed a benzodiazepine and has been on that medication for a long time, adding Suboxone to that, especially if they've been using illicit opiates, is actually going to be safer. I guess maybe the way to explain this the best is, like, oftentimes I'll see a patient with alcohol and opiate use disorder. And so a patient is drinking a lot of alcohol on a regular basis. Their body is used to that. They've also been using opiates at a high level. What I want to do first is I want to stabilize their opiate use disorder. So we're going to talk about the alcohol, and we want them to reduce their alcohol use. But generally, it's going to be safer for me to add Suboxone to that situation because it has less dopamine, release, and so less side effects. And so again, with any medication, there's going to be some side effects, but if the thing I want you to just think about here is just like, if a patient has already been on these medications for a long time, or if they've been taking them in combination, adding Suboxone is generally going to be safer. But for a patient that's, naive to benzos or doesn't use alcohol often, they really do need to be educated that taking those with the Suboxone can cause some increased sedation. Again, buprenorphine metabolism, it's metabolized via this CYP3A4 liver enzyme. So, antivirals, some antibiotics, antifungals can cause an increase in the buprenorphine levels. Again, the thing to think about here is just like, because of the ceiling effect of the buprenorphine, it oftentimes, especially if patients are already on a pretty high dose, 12, 16 milligrams, this increase is probably not going to affect them in any significant clinical way because the higher levels of buprenorphine in their system isn't going to cause a problem. I would probably pay most attention to this with patients that have lower dose buprenorphine. So, 1 or 2 milligrams, something like that. This increase may cause patients to feel more sedated or more sleepy. So something to be mindful of. Mainly with some of those antibiotics, a lot of times patients are not on the other medications. But if they're on those medications already and using opiates, again, still use the Suboxone. Okay, so true or false, patients with opiate use disorder taking CNS depressants are not candidates for maintenance pharmacotherapy with buprenorphine. That answer is false. Patients using CNS depressants such as alcohol or benzos should receive buprenorphine. Maybe monitor them more intensely. So, all right, let's talk about side effects and precautions. So again, understanding common side effects associated with buprenorphine is really critical to appropriate patient education and management. Again, buprenorphine is considered a safe medication. There's a few precautions that should be shared with the patients prior to initiating treatment. So here's a list of side effects. Obviously, any medication that is prescribed to somebody has a million side effects listed depending on the person, but the most common side effects are headache and nausea. Obviously, people can get into withdrawal syndrome that we talked about. Constipation is pretty common with the medication, so you can prescribe some stool softeners. Less common, diarrhea, chills, vomiting, peripheral edema does happen from time to time. So the main thing I just educate patients on is kind of the nausea, headaches, and if they have the peripheral edema, obviously we'll talk about that. So here's a couple of the sort of most critical precautions. So again, I kind of hit this already, but make sure that you tell people to avoid alcohol and CNS depressants. It's really important that you tell patients when you prescribe Suboxone to keep the medication stored in a safe place. So we generally tell our patients to get a lockbox or provide one for them, but keeping their medication stored safely. Theoretically, if a child or somebody who's never used opiates before got a hold of Suboxone, kind of got it in their mouth and absorbed it, it theoretically could cause an overdose. And so really want to make sure that patients are aware of the safety profile. I do always prescribe Narcan to my patients, even if they just have it. So if, I tell them if a child or somebody gets a hold of it, give the Narcan, call 911 right away. There are some new data out there about buprenorphine being hard on people's teeth over a period of time. And so trying to make sure patients rinse their mouth out, brush their teeth an hour after, or maybe you can switch them over to an injectable form of the medication. And then always just telling patients not to misuse or divert the medication. So again, what are two of the most common side effects of buprenorphine, and what are some strategies to mitigate the recurrence of these symptoms? Essentially, headache and nausea are the most common side effects that we see. Generally, this will get better with time. Sometimes if you do encourage patients to spit the medication out instead of swallow it, for whatever reason, that seems to help them sort of mitigate some of those side effects. So just a little tip there for you. All right. So yeah, a little bit of wrap up and application, and then I'll try to leave a few minutes here at the end where we can go over some questions or talk through some case studies with you. So again, buprenorphine, it's the preferred agent in the outpatient setting. It's really become the gold standard for opiate use disorder in the outpatient setting. The reason that it's what I would argue the best or convince you to prescribe it is because it's got a better safety profile, minimal side effects, great efficacy. They can be treated with flexibility. They can take the medication at home. They don't have to go to a methadone clinic. Again, almost every single patient that presents with opiate use disorder can be prescribed Suboxone. There's different options for that if they have some side effects. And then again, investing the time, if you can, give them a dosing sheet or whatever, but proper dosing is really going to be important for patients doing well on the medication. I just did a training, actually it was just 2 days ago, and one of the ways that one of the providers I work with communicates this, it says, it doesn't matter how much medicine I prescribe you, it matters how well you take it. So obviously that's an overstatement, but I do just want to highlight that taking the medicine correctly is really going to help patients feel really well. One other sort of quick side note on the dosing of the medication is generally, because the medication is long acting, when patients start taking it, they're paying attention to their dosing and they're doing a good job and they start to feel better. But the analogy I use is if you come to me with a sinus infection or some sort of really bad cold, and I prescribe you an antibiotic that you should take for 10 days, when you feel terrible, you're going to really be diligent about taking that medication twice a day. And then as you start to feel better, just because you're a human being, you will eventually kind of forget to take it or you'll get distracted. And so similar things happen with Suboxone, where patients are feeling good, they're paying attention to their dosing, but then they get a little bit lax with it. They get interrupted by their kids. They accidentally swallow some of it before they hold it in their mouth. And so again, the proper dosing is really important. All right, I'm gonna spend just a few minutes talking about initiation. I'll try to leave about maybe 10 minutes here at the end so we can do some questions. But when you start patients on Suboxone, we sort of have talked about how to take the medication and have the precipitated withdrawals, but how do you actually get them on the medication? So there's lots of different ways to do this. The most common way to do it is what we call a conventional initiation, which I want to talk to you about. And then there are other ways, high dose initiation and low dose initiation, and I'll kind of talk through those briefly and have a few slides that you can look at. But generally what we're telling patients that are using a short acting opiate is that the goal is we want them to try to wait at least 24 hours from their last opiate use. Now, if they're using a long-acting opiate, extended morphine, or fentanyl, patients may need to wait longer, up to 36 hours. But generally, if you can have a patient wait 24 hours from their last opiate use, what we'll have them do is we'll have them sort of says step one, take a small piece of the Suboxone, so either 1 or 2 milligrams, depending on what the target dose is. Let's say the target dose is 8 milligrams a day. So you'll have them wait 24 hours, take 2 milligrams of Suboxone, again, hold it under their tongue, do the whole dosing, wait 60 to 90 minutes, and then as long as they're not feeling really terrible, have them take another, 2 to 4 milligrams, and then another 2 to 4 milligrams after. So again, only if a patient is like using something, some sort of long acting, are they really going to get into some significant withdrawals. But generally, once they take the Suboxone as an onset, 60 to 90 minutes after, they're going to start feeling a lot better on the medication. So this is the primary way that we help people get on the medication. On the side here lists some just like medications that we'll use to help people during this withdrawal period, during the first 24 hours, and even while they're initiating on it. So often we'll use clonidine a couple times a day, or Vistaril to help with anxiety and sleep, Zofran for nausea. And then I listed the Narcan there because that is prescribed to all the patients. So this is primarily what we use, and most patients will do really well on this. So let me talk to you for just a minute about a low dose initiation. So this is used primarily for patients who are using fentanyl in really high amounts, or patients that are transitioning from methadone to Suboxone. That transition from methadone to Suboxone can be hard because the buprenorphine will block the methadone. So methadone, again, is a really long-acting opiate. It stays in the system for like 7 to 10 days. And so there is some controversy around this type of initiation for fentanyl patients, but essentially what we're doing is we are very, very slowly giving patients buprenorphine over the course of, this is 5 days in this example, but you sometimes will do it for 7 days. And what you tell patients to do is you tell them to continue their baseline opiate use. So that obviously can be kind of scary for patients, especially if they're using fentanyl off the street. But essentially what we do is we have them continue the fentanyl use. We slowly give the buprenorphine. And as that begins to block it and gives some dopamine, they continue to use that. And then once we get up to this threshold, we're actually able to make that transition off of the fentanyl and onto the Suboxone. So again, we don't love telling people to continue to use their fentanyl, right? But for certain individuals, what was happening is they were using fentanyl. They could not wait more than 6 hours before they were super sick. If they took Suboxone, then they would get even more sick. And so it was really important that they sort of be able to microdose. So again, I just want you to know that that option is available. And then again, here's a third option. I use this option the least often, but let's say somebody's using fentanyl and they come to me and they say, hey, I have no more access to fentanyl and I want to start on Suboxone and I want to be done, but in 6 hours, I'm going to be on the floor sick. And so in these situations, again, if a patient can go to a methadone clinic, that's ideal because that transition from fentanyl to methadone is the easiest. Patients, we'd recommend that they go to an inpatient setting or a detox setting, but if they refuse all of those things, then what we'll do is we'll have them try to wait 24 hours as long as they can, give them withdrawal medications, and then we'll give them a bunch of Suboxone, either 8 or 16 milligrams all at once. And then an hour later, we give them another 8 milligrams. In another hour, we give them another 8 milligrams, all the way up to like 32 milligrams above the max dose. And so what we're trying to do in that, again, is just get enough buprenorphine on board, enough dopamine receptors so that the patients can actually start to feel good. Some people do well with this. And again, in the right patient, it's just another tool to have available. This is just a quick conversion rate. I've been using this for a long time. There's lots of different ones on the internet or whatever. But again, just to show you, like a short-acting opiate, 50 to 75 milligrams, even 75 to 100, somewhere around 8 milligrams of Suboxone. IV heroin, which is much less common now. We see a lot more fentanyl, but kind of gives you an idea when patients are using it. And then the methadone dose equivalents, if they're greater than 80, somewhere around 24 milligrams is going to be a target dose. So again, these are just, patient specific at times. So, all right, Will, I'm going to get this done and give us some time for questions. So this is just the last slide here is just the Echo team. Will kind of put that out there before. Great group of people that want to be helpful to you. I did throw my phone number on there because I literally do this all day long and would love to talk to you if you have a question about that. If you call me, I won't answer. I'll send it to voicemail, but if you text me, I might respond, or you can leave a voicemail that way. But just want you to know, email Will, like our team is available. We really want to be helpful for you. So, all right.
Thanks, Ed. Great presentation.
Thank you.
We've got 10 minutes. Anybody have a case, or we can bring some questions forward? Open it up. There was a question about regarding grapefruit juice and pomegranate juice in the chat that Janet and Gail answered. Thank you.
Excellent.
But yeah, feel free to, you're welcome to unmute if you want to bring a question forward or drop something in the chat. We've got 10 minutes, or we can have, oh yeah,
quick question. Yep. Hi. Thanks for that presentation. Can you talk a little bit about maybe patients that are on the lower dose opioids and how, if you just start them on the 2 milligram equivalent, or how that works? I've got just a patient that takes, daily Norco, and I don't know if it's something we just continue to prescribe, or if this is a good option for him.
Mm-hmm. Yeah, that's a good question. What's do you know how much Norco they're taking a day, or are they?
I was trying to remember, but I can't remember exactly. Sorry.
Yeah, we can take a guess on it. And again, the buprenorphine. So primarily what I've been talking about is sort of like patients that have like an opiate use disorder. So they've been like abusing the medication or overtaking it, sometimes in higher amounts. So again, the Butrans or some of those are a much lower dose. I'm not quite as familiar about what exactly to do with the Butrans stuff. We have Dr. Massey, who's not with us, but he does a lot of the pain stuff. But essentially the way I would answer that is just like, hey, if it's becoming something where they've been dependent on it and they need to go on the Suboxone, what you can do is just, again, try to have them wait 24 hours, and then you can slowly start the Suboxone. The Butrans dosing, if you're just doing it for pain, is much lower than the low dose of Suboxone. But you can even do, 1 milligram or a half a milligram of the Suboxone, like the 2 milligram strip. You can cut it down into really small pieces. So the other thing is like, just trying to understand like what the patient's goals are and desires are. So even if they're on a lower dose of like hydrocodone, you can actually give very small amounts of Suboxone to and sort of microdose people. But generally, patients that are just on like a baseline Norco are going to be able to wait 24 hours from their last use of that, and then we can introduce the Suboxone in slow amounts, and they'll do pretty well. So,
Thank you. Yeah, that helps. Yeah,
okay.
Thanks.
Yeah, you bet.
I have a question. I have a question for all of you. Have any of you started using, how many of you use Suboxone? I guess is what I'd like to know. Or have you started using it? Are you considering using it? We just like to kind of know if this is changing hearts and minds at all.
We want to know if I've convinced you to prescribe.
That's right.
Suboxone. I really want to convince you to feel comfortable to do that.
Got a couple of prescribers in the chat.
Yeah.
Someone kind of considering it.
Yeah.
Yep.
Perfect.
And I did add a question on this on today's evaluation survey, so we can
good.
collect some information from our participants there too.
Yeah.
Hopefully starting to feel more comfortable.
Yeah, that's great. It's looking like a lot of people are. I think, it's like any kind of thing we do in medicine. The more you use it, you'll find what works for you and your patients, and wonderful. It's good to see. Congratulations, everybody. Thank you.
Yeah, it's really good. Again, even if you've been familiar with Suboxone for a long time, like there's always seems to be like cases that come up for me where I want to talk to somebody about, hey, what do I do about this, or what are we concerned about with that? And so I just really feel like, especially as you're getting started, just having someone to bounce that off of can just be really, really helpful. So we obviously, like we said, we want to be supportive in that, in whatever ways that we can. But once you start doing it, like Janet said, you'll realize it's really a great medicine that people do really well on.
It really does save lives, and it changes lives, because being chronically addicted to opiates is not conducive to a normal, healthy life. It's hard to raise your children. It's hard to be in relationship. It's hard to have any money. And my soapbox thing is I think our government unwittingly did us a great disservice by having the waiver, because they put roadblocks up to use it and have made it difficult now to convince people that it's really the standard of care. And gosh, it just feels like sometimes it's so hard to get over that hump now, and it should never have been that difficult to use. Oh, I don't think I said obesity. Did I say obesity? I meant opioid use disorder. I probably blurted something out. No, not for obesity. So if it works, let me know.
We had a question about some sending out some patient education resources. I have some booklets that I can send out, as well as some other things. I'll also make sure to send out Ed's slides. Those seem like they'd be a good resource for a lot of people. I do have, in terms of patient education, I have some little ASAM booklets, Kelly, that I can send out. I'll get in touch with you about that.
Will, don't hesitate to give out our information too. I always think it's kind of important for us to say, if you have questions, just reach out to us individually on kind of a curbside basis. We're always happy to do that.
Yeah, absolutely.
It's usually a lot simpler than you think, and we can walk you through things if you have any questions about hard ones.
I can attest that Dr. Massey will get back to you. I texted him and he got back right away. So it's super helpful. But yeah, we all want to be good resources there.
Oh, it just came in now? Yeah.
All right. Well, if I don't see any more questions, we can end here a minute or two early. Again, I threw in a link for the evaluation survey in the chat. Also keep an eye out for an email from me coming this morning sometime. If you don't see that, again, check your junk mail. For some reason, it's going to people's junk mail last week. And we will be back in 2 weeks. Stephanie is doing a talk on treating patients with ADHD and substance use disorders. So looking forward to that one. And
You might answer real quick. There's a question. Are there samples of documents that need to be in place to prescribe? We should probably address that before we quit.
Thank you.
Yeah, what documents are we talking about? Like, do we have to, like, talking about like documenting like the diagnosis criteria, or?
I wonder if she means like consent forms or patient contracts. I think that's individual. There's a lot of controversy about patient contracts and such. And so I think it doesn't hurt to have a very intentional discussion about, this is how I want you to use it. I don't want you to misuse it. And you can work up a little form like that. It is not required that you do that. That has to do with your own comfort and your own practices, your own guidelines within your practice, but there's no legal requirement for that.
The SAMHSA site also has sample forms to use that you can draw from or just take whole. So if you go to that site, into the MAT, that's something you can just get online.
I'm sorry to interrupt. I just saw that. I thought we better address that before.
No, thank you. I'm glad you did. I didn't
Yeah, definitely. Yeah, I mean, I'm sure that the place where I work, they do something, but I don't. Yeah, it's not a legal requirement, but it may be helpful to have on hand for sure.
All right. Well, hey, great job again, Ed, and hope to see everyone back here in 2 weeks. Thank you.
Okay.
Thanks,
Good job.
everybody.
Thank you, Ed. Very good.